We are now.
Alrighty. Well, hello everyone. I think I've seen a couple of you a few weeks ago at the OSCE, but for everyone else who has not met me yet, my name is Dylan Tulett. I'm a PGY1 resident at Baptist Health Louisville. Um, I I guess Becca, I'll let you introduce yourself.
Hi, like Dylan and Dr. Malcolm said, um, we're both Sullivan alums. My name is Becca Doyle. I am a PGY1 pharmacy resident at Owensboro Health in Owensboro, Kentucky.
Becca, it looks like your mic is pretty low. I don't know if you can turn it up.
Mm.
If you go into the mic volume, so like if you click on mic at the top, it should have microphone, and then there should be like a little.
Um, I will let you play with that, and for
Yeah.
time's sake, I'm going to go ahead and get started on the lecture. So we're going to be talking to you all about obviously medication safety, which you've been doing an entire course on, but we're going to be focusing a little bit more on the health system and like hospital medication safety, kind of going over some things that I wish I had known. I'm sure Dr. Doyle wishes she had known before going into IPPs and APPs, and even beyond that, if you choose to pursue health system pharmacy in the future. So this is going to be broken up into two parts. Roughly, the first part is going to be newer content that's going to be pertinent, just like for your information on APPs. Like I said, this is going to be focused much more on like the actual processes of health system pharmacy, and different mechanisms for health safety or medication safety. And then the second part is going to be over some things that you guys have probably touched on before. I think that even some of this stuff you've been tested on before, but these are areas that Dr. Doyle and I both thought were very important on the NAPLEX and on the MPJE. And so it's worth going over again and worth making sure that you really have that stuff down pretty good. But first, just to go into the medication use process, one thing that I kind of wish that I had a better grasp on going into APPs or IPPs was just like who I go to for what information, or like if I'm struggling with something, like who does what in the hospital. And so these two like technicians and pharmacist roles are pretty similar to what you would see in an outpatient pharmacy, but I'm going to go over them um, and kind of share some of the differences. So pharmacist role, generally what I think about is the pharmacist role is like two aspects. So there's like the medication safety aspect where it's like actually verifying orders or verifying products to make sure that nothing is wrong with them. Um, like making sure that the timing of everything is appropriate, that the dose isn't too high, all those different things. And then there is the kind of like evaluative, subjective portion of the pharmacist role, which would be like actually looking at if the medication is needed for a certain disease state, triaging questions from nurses and providers, more so that not so by the book, strict, like law based stuff. That's a little bit more subjective. And then the technician role, really the way that I see it is like everything they do is in support of the pharmacist. So the pharmacist may be verifying a product, but it's the technician that's compounding it and pulling it and delivering it. So they really like operate the pharmacy um, at the nitty gritty level that the pharmacists don't necessarily. It's also worthwhile pointing out here that pharmacists can do all these things that the technician can do. It may not be the most effective use of their time, but in emergencies or in situations where you're short technicians, I've certainly needed to compound medications before as a pharmacist. So, don't think that necessarily like pharmacists are above doing any of these other things. Now on to more of the medication use process. The first part of the process, of course, is going to be ordering of the medication. This is done by providers, pharmacists, nurses who have been given orders from providers. A lot of people in the hospital will order medications. And so it's a really big point of potential hazard. A couple of the ways that we try to overcome those medication hazards is by implementing a lot of guardrails for people. So there are recommended orders that you can see based on a patient's disease state. Some providers might have frequently used orders that they have in like their little hotbar. So that's one way to kind of like guide people towards more consistent prescribing or ordering. There's also order sets. So for any disease state, and we'll take a look at an example here in a second. For any disease state, there might be many medications that you want to order simultaneously. And so there are these order sets that just allow you to basically select it and go through and make sure that everything you want is in there, but it's a way to guide people towards appropriate treatment. And then, of course, there's going to be built-in hard stops for ordering, and we'll take a look at that in just a second. Yeah, and that's a great point, Becca. If anybody has any questions, throw them into chat. We're both looking at it, or just raise your hand, and I will try to call on you. So this is the screen that you see when you're, oh, let me go back, when you're ordering medications or an order set. So this is just one example. The CWA protocol is for alcohol withdrawal. A few things to note on this screen. We've got that browse tab, which allows you to go see like recommended orders for different disease states. That's what I was talking about earlier. And then this preferences list is where providers can kind of like star orders that they use frequently in whatever domain they practice. But then this facility list is where you'll see kind of like most of the medications that we provide in the hospital. And so this is one type of order set that you could get. I also want to draw your attention to this database list. This is something that, at least at our facility at Baptist, only pharmacists have. It's a way for us to be able to order a non-formulary medication or something that we don't have in stock that we plan to order for a patient, but we don't permit nurses and physicians or NPs to be able to see all of those medications, because this is one way that we can have kind of like more safety and more control over potential medication errors. And so now what you're looking at here is an order set. This is actually, it's a different order set. This is for C. diff order set. You can see there's only actually one medication here. So a lot of orders will be other communications or ways to do things that aren't necessarily medications. So you can have labs, you can have consults, you can have communications to nurses. So in this order set, we have just a communication that this patient is in isolation precautions. We have 2 consults for pharmacy to intervene on their medication list. There's a social services consult, and then there's only actually 1 medication included. And so all of these other things are ways to make sure that things are being done appropriately in the proper operating procedure. But let's take a look at this medication that we have. So we're ordering Difficid, and that is just an antibiotic used for C. diff, but it's got some restrictions on it. So if you look over here, when I try to sign this or verify it, it's going to pop this up because there are these alert hard stops that I have to address first. So just as an example for this medication, you can only give it if the patient's at high risk of recurrence. So that would mean they have to qualify for one of these things first before we can order this medication for them. And that's just an example of one type of hard stop, but there's plenty of others that we put on drugs just to make sure that things are being prescribed or being ordered appropriately. So once we've done that, we've put the order in for a medication. It still needs to be verified by a pharmacist. Now, if you are a pharmacist, you can order and then verify your own stuff. Some people choose not to do that, which just puts in another aspect of medication safety, like don't verify the things that you order. But regardless, we've ordered, now we're going to verify. And there's a few different types of safety procedures in place for verifying. We've got these various alerts. So an alert on allergy, duplicate medication in the patient's chart, dosing, frequency, or strength is too much. There might be an interaction with one of the other patient's medications, or there may be some specific medications that are contraindicated in certain populations, such as pregnant patients or older adults or potentially neonates, several different special populations that you have to consider. And obviously, like, we're drug experts, but our brains are not just databases of drugs. So this is one way to help us catch some things that get slipped by us. Some of the other things that we have available during verification include dual sign-off, which is exactly what it sounds like. That's just when you need two different people to verify something before it's released for the nurse to give. At Baptist, we use this specifically for our neonatal population. Any orders that are being given to neonates require two sign-offs, and then any chemotherapy orders that are ordered require dual sign-off. Of course, at the point of verification, there's a lot of documentation that happens. So any kind of issue or anything that seems kind of like outside of the norm for an order, if it ends up getting put through, or there's anything that you want to monitor as far as labs for a certain medication, a lot of times pharmacists will put in documentation on a medication just saying, like, follow up with creatinine clearance or whatever it may be, follow up with potassium labs, just to make sure that we are reviewing medications on an ongoing basis, even though we're releasing them to the team. So this is one type of alert that you will see. I should note both Dr. Doyle and I work with Epic. That's just the specific electronic health record that we use. There are other ones, but all of the images that you're going to be seeing are from Epic. So I just wanted to give that caveat. So this is just an alert saying that a medication, hydralazine, that was ordered is going to be available to give more than 25 times in a day. What this order probably is an as-needed medication that's like every 30 minutes or whatever it may be. And so it's probably not going to be given 25 times in a day, but it's just potentially available that much. And it's okay to say, like, yes, I'm aware of this. I'm good with this medication being given. It just wants to make sure that that was the intent. So we're not ordering, like chemotherapy 25 times a day or something ridiculous like that. But most of the alerts are going to look like this in Epic. Again, if you go to an IPI or an API somewhere that doesn't use Epic, it'll look different, but the concept will be the same. So this is an alert for a medication order for acetaminophen, 325 milligrams. It's being used only in recovery. So as soon as this patient is outside of recovery, this will fall off. That's just another medication safety apparatus. It's being used in a patient that had eyelid repair surgery. So yeah, we probably want to get them pain medication. Problem is, Epic is flagging an allergy. So let's look at what it is. They had itching when they took hydrocodone and acetaminophen. I know we haven't necessarily done therapeutics or pharmacology yet, but for your information, itching is a known drug reaction with some opioids. So when I see this, I'm thinking probably this is more so the hydrocodone causing a expected drug reaction, not the acetaminophen. Okay. So this would be one that I'm okay pushing through. In order for that to happen, we need to clarify for Epic why we think this is either incorrect, or even if it's a true alert, like a true contraindication, why we still want the medication to be given. So we can say the benefit outweighs the risk. There was an inaccurate warning, which is probably what I would put in this situation. We can look at the patient's previous medications and see if they've taken acetaminophen and had an okay reaction, or had no reaction with it. You can always say ordering provider acknowledged, because the ordering provider wanted them to get this medication. And then you just need to select one of these and override it. So now we've verified the medication. We got an order from a prescriber or pharmacist or nurse, whoever it may be. We verified it. Some medications will need compounding, which I think you all have already seen sterile and non-sterile compounding at this point in the year, if I'm not mistaken. And so let's go look at some of those safety apparatus that are available for compounding. Probably I won't say the biggest one, but a really important one for not just compounding, but like everything from here on out is going to be barcode scanning. So we have a verified medication that we want to give to a patient. We want to make sure we're giving them the right thing. So take all of the human aspect out of it. I know, sucks, but we want to basically robotify the medication process from here on out. So scan the barcode, make sure the barcode matches exactly what we have in the order. We also have pre-built medication formulas or recipes within Epic or any other EHR. And that just helps standardize what we're creating. There's compounding machines, which again is just like a robotic process that helps us get exactly the quantities that we want. We have mid-prep review. Mid-prep review is basically within an electronic health record, you're able to take images of a medication during compounding. And so if you've drawn back a syringe before the tech goes ahead and puts it into the bag, they can take a picture, send it to the pharmacist, and the pharmacist can verify this is the right drug, this is the right quantity, and then we can release it for the technician to complete the process. I just talked about prep imaging. We do it in mid-prep review as well as at the end of the whole process, so we can verify all of the medications that get compounded. And then again, dual sign-off. Different facilities use dual sign-off for different patient populations or like disease states, if you will. I said earlier, we use it for neonates and for chemotherapy mostly. Okay, so this is just to walk you through a little bit of how medications get compounded and to show you these things in action. We can go and like try to batch a couple of bags of vancomycin. So I type in vancomycin, and instead of just like calculating it myself and trying to do all this math that can potentially, I mean, you should also be verifying it that way, but we have these preset formulas. And so our technicians just need to type in what the order is, select it, and then we get into this compounding screen. So right off the bat, there's multiple safety mechanisms that I'm noticing. First, we have our pre-selected medication. There's a recipe on the side so that the technician, if they're not familiar with it, can kind of read up and become familiar with what they're doing. But then beyond that, we have these ingredients, and this is where the barcode scanning is going to come in. So we will scan each ingredient that is needed. This Epic knows how much you're scanning based off the barcode. So let's say you were doing like 10 bags and you needed a ton of vancomycin. Scanning one vial wouldn't be enough to please Epic. You would need to scan all of the vials you need. It records the expiration date, completely blanking on the word, but it records all of the information about it. So scan the vanc, scan the sodium chloride, and then you can see, like I said before, take a picture and send that off to the pharmacist before it is verified. Yeah. So this is the pharmacist perspective after the technician has completed a batch of vancomycin bags. So I can see vancomycin 1500, we made 7 bags. They used 2 vials of vanc. Lot number is the word I was looking for before. So I can see all of the products that were scanned. And then I get these images of the vials, the sterile water, all of the bags of normal saline. And then I can also see the syringes and where they were drawn up to. Now, this is a huge improvement. I don't know if anybody in the class was an IV technician previously, but when I was an IV technician through pharmacy school, we had what was called the drawback method, which was basically I would make a medication and then just draw the syringe back to wherever it was supposed to be drawn back to, or it's supposed to be wherever I had drawn it back to. Obviously, we're human. There were multiple instances where I made a medication, completely forgot where I drew it back to, and had to like call the pharmacist and be like, hey, I can't say for sure that I drew this back to the right quantity, and I had to make it again. So being able to take pictures is definitely much better. All right, now coming to the compounding machine. This is mostly used for just making TPNs, which is total parenteral nutrition. Can also make different fluid medications. So like if you wanted to give sodium bicarb or something like that. Just a few things to point out about this. I won't get too into the weeds, but you got your medications. They attach to the brain, which attaches to the bag. This system has barcode scanning, which is great, but it also doesn't communicate with Epic, which is not great at all. So there's actually 3 systems involved in making a TPN. You have Epic, where you get the order from the doctor or pharmacist. You have Abacus, which is the software not in Epic, where you type in the formula for it and type in the recipe, and that's a completely human process, very error prone. So we absolutely have dual sign off on that. And then that prints out a label that gets scanned into Baxter or Exactamix. So it's a very complicated process, high potential for error. So there's a lot of pharmacist eyes that end up looking at this every day. All right, so got an order, verified it, compounded it if it needed to be compound, or didn't if it didn't need to be compounded. I'm sure you all have talked about tall man lettering in dispensing before. Absolutely, that kind of goes hand in hand with stock organization. You don't want to put 2 things with similar names right next to each other. At this part of the process, we still have barcode scanning. I'll talk a little bit about carousels and robots on the next slide, because that's a little bit, I don't know, it can be new for people, especially like some outpatient pharmacies don't necessarily have this yet. At Baptist, we use something called Tech Check Tech, which is, I think, used at a lot of different facilities. So you'll probably see it throughout your IPPs and APPs. But basically, a tech pulls a medication off the shelf, barcode scans it. They can hand it to another technician who then goes in, barcode scans it again. So there's two people checking it, two different barcode scans, making sure we have the correct amounts, the correct drug, everything. Automated dispensing cabinets kind of goes hand in hand with carousels and robots, but they're slightly different, and I'll talk about that. And then again, documentation. Sometimes there's medications that for some reason aren't in Epic, don't get barcode scanned the same way, and we need to like document, or like the pharmacist needs to visually sign off on it. Huge potential for error in those medications, but typically those are the less hazardous medications anyways, which is nice. Okay, so two different types of automation. Medication carousel is within the pharmacy. Automated dispensing cabinets are out on the floors. So the medication carousel, both of these, again, caveat, Baptist uses Omnicell. So our EHR is Epic, our dispensing system, and our like medication cabinets are Omnicell. Epic and Omnicell do communicate, which is awesome. There are Epic downtimes and stuff like that in which you need to like override medications from Omnicell. I'm not going to go super deep into that, but know that there are times where it is more hazardous because we're not going off of the communication between the two softwares. But to get back to it, we have a medication carousel. Orders from Epic that have been verified will populate into this computer screen. The technician literally just needs to come up, tap on the order that they want to pull, and this carousel will bring them right to the medication. There's a big LED strip that points them at the medication that they need to pull. Very easy and intuitive. They pull it, barcode scan it, put it in a bag with a label. All good. And then from the pharmacy, that gets sent out to a specific patient. Automated dispensing cabinets are going to be like repositories of medications on units. So we will have different meds in all of these drawers. In here, there are like locked drawers. And so the nurse or doctor or pharmacist, whoever's on the floor, will come up. They have to like badge in or fingerprint in, click on the patient they want, click on the medication that is in that patient's chart, and it'll open up just that drawer for them to take. So very safe most of the time. So now we've pulled our medication, getting into administration. So this is more so from the nurse's perspective or potentially from the physician or NP, whoever it may be, giving the medication. Of course, barcode scanning at the bedside again. We'll have dual sign off with another person for like hazardous medications, anything like that, anything that requires extra eyes on the medication being given. And then there will be some form of documentation that the nurse gave a medication. Sometimes that documentation is just, I scanned a Tylenol into Epic and that creates the documentation that it was given. Sometimes if it's something that's more cumbersome or dangerous, the nurse will also write something in there that they documented the administration. And then we've talked about non-communicating technology already, but this is another instance where, again, there's a different company that gives us the pumps for IV bags. And so at Baptist, caveat again, you might see a different company use it, like a different hospital use a different pump company. Baptist, we use Alaris pumps that don't communicate with Epic. I think that like theoretically there are communicating pump EHRs out there. I have not seen them, but this whole process, as you can see, requires human interaction to type in what medication it is, what the strength is, how fast they want it to go. And I get a lot of nursing questions like, what rate do I put this at? Because Epic is telling me it's in like milligrams per hour and the pump wants it in milliliters per minute or whatever it may be. whatever it may be, like there's a huge potential for error here. And then, so once the medication is given, we're obviously going to want to monitor the patient. Just like I said, when we're documenting at verification, like, patient got potassium chloride, monitor their potassium levels. There's going to be documentation here, like patient is currently on propofol, monitor their triglycerides, whatever it may be. You want to be documenting what is given and any kind of potential side effects that you're looking at. Other safety mechanisms at this point are dosing consults from pharmacy. So for things like warfarin or vancomycin, we're going to continuously monitor patients on certain medications and actually dose them from pharmacy. So it's not the physician deciding the dosing, just because we're the drug experts. We know pharmacokinetics better than anybody else. We're going to be the ones who are deciding what doses they're getting on an ongoing process, like looking at their labs and chart and everything. There are lab panels that you can order. So if I have a patient who is on TPN, I'm going to continuously be ordering every single day all of their electrolytes to make sure that they're not going low or high. Obviously, we have the EHR, which I'll show you two different points of view of the EHR in a second, which would be the nursing versus pharmacy MARS. So this is the pharmacist's view of the MAR, which is the medication administration report. As you can see, we've got some medications, we've got some tall man lettering, obviously, which is a safety mechanism. What I want to point out here is that this is designed for pharmacists. So we've got dose, we've got a lot more like granular detail about like when it was given. Green means it was given, the black is like still yet to be given, and then red is any missed doses. You can see these orders are linked, things like that are much more like granular about the pharmacist's viewpoint. And then you have the nursing MAR, which has a lot more administration information. So, caution, this is a look-alike, sound-alike drug. Don't give the patient grapefruit juice. You can give it within 60 minutes on either side of the administration window. Dispose of the controlled substance in a waste container. Different things that they need to know. So I guess the point of this whole section is just that most EHRs are like customizable for a user, which is a fantastic safety feature because it's giving the nurse just the information that he or she needs. It's giving the pharmacist just the information that he or she needs. And then this is an example of the documentation that I was referring to. So this was a patient that I was watching and documenting on. They were on propofol. We ordered triglyceride labs to be collected on an ongoing basis, like we talked about. And then I'm just kind of making a note to all of the pharmacists, like patients' triglycerides are going up, like not necessarily at a level where we need to stop it, but keep looking out for it. All right. And now let's do a little bit of review. So I'm going to ask everybody to send their answers into chat. The question is, what type of safety implementation is designed to prevent dispensing a look-alike, sound-alike medication? A, medication alerts during order verification. B, pre-built medication recipes during compounding. C, barcode scanning when the technician pulls medications. Or D, a nurse using the EHR to document a medication is given. Go ahead and throw your answers into chat, and I'll give you a minute or two to do so. All right, looks like we got Looks like we got a lot of good answers, and the answer is C. The barcode scanning is going to be the one that prevents dispensing the wrong medication. All these other ones, obviously important medication safety features, not going to prevent dispensing the wrong medication. Now we're going to talk about classification and response to errors. So there's three, I grouped into three different types of medication errors. There's errors of omission, errors of commission, and then there's just adverse drug events, which I guess I shouldn't say medication errors. I should say medication events. The first two are definitely errors. An error of omission is where you don't do something that results in an error. So I didn't verify this medication. I let it sit there, and the patient needed it because they needed epinephrine for an anaphylactic shock, whatever it may be. So there's a lack of action that resulted in an error. So this is a negative error. An error of commission is a positive error. So I did something that resulted in an error. Let's say I put two medications into an IV together that aren't compatible. That's me doing, like, actively taking an action to do something. So it's an error of commission. This is a positive error because there's a positive process of doing something. And then there's adverse drug events. This is not an error. It's a known reaction. Every time we give someone a medication, there is something that can happen that we know can happen to a certain percentage of the population. And it's not something that we did wrong. It's just unfortunate. Medications have side effects. I'm going to let Becca take over these slides.
Bear with me for a second, y'all. Okay. Maybe.
If need be, I can share my screen again. If you want to, let me know like when to move on.
Yeah, that might be a little easier,
Okay,
unfortunately.
it's all good. Just some snow day medication, or not medication, snow day technology issues.
Always. Okay. So I'm sure y'all have heard about a Sentinel event at this point, but just to kind of go into it a little bit more, the Joint Commission monitors what we call Sentinel events. So that is a patient safety event that reaches the patient and results in a serious event. So it could be death, it could be any kind of permanent harm. So even if it's mild harm that's permanent, that's never going away, that is also classified as a sentinel event, or any kind of severe harm. So patients' respiratory rate drops or their heart rate stops for any amount of time. They didn't die. They don't have any kind of permanent damage from it, but that's a severe harm. So we're still going to classify that as a sentinel event. And then, Dylan, if you want to hit next for me. So we have different types of systems to report any kind of error within each health system. I know Owensboro uses what we call IRIS, and then Baptist uses a SAFE report. They're both utilizing the same database, which is RL Datix. Not that that part is super important, but the fact that each institution is reporting their errors, they're reporting their safety events, they're reporting near misses, unsafe conditions. And if you look on that little screen grab there, you can see all of the different potential classifications. So we have, you know, something happened in imaging, or something happened with their airway. They had a drug reaction. They had a medication error. So any of those would be reportable. And then, Dylan, if you want to go to the next slide. Yep. So we have all the different fields that you fill out. Dylan and I compared our reporting systems look the exact same. So they want to know everything about this event that they possibly can. So they want to know who was there when it happened, who did the event, reaction, error happen to, where was it, when was it. So all of your who, what, when, where, why, how, they have a form to fill out. And then if we go to the next screen, so that's just all the information about who was affected. So you can see like their name, their age, sex, race, what's their language. So was this a communication issue? Do we need to get a translator to talk to them and explain what happened? And then if we'll go, yep. So, all right. No, you moved too fast. Okay. So we have our error evaluations. One click, please. So our goal here is continuous quality improvement. We can either be looking backwards, we can look forwards, but we're always wanting to make things safer for the patient. Does anyone remember? We've given it away, but if you weren't paying close attention, does anyone remember our causes of, or our types of error analyses? You can raise a hand, drop it in the chat. And if we get nothing, I'm going to assume that y'all don't remember, and it's a good thing that we're going over it. Okay, one click, please. So we have a root cause analysis or our failure mode effects analysis. Can anyone remember anything about either of these? Because I know Dr. Malcolm has gone over them with you, at least somewhat. Fair. So for our root cause analysis, if we can have a click, please, Dylan. This is a retrospective event, or a retrospective analysis looking back at any kind of event that we've had. The Joint Commission actually requires this to be performed after any kind of sentinel event. We're trying to look at what actually caused this event. We want to look and see if there were any system factors. So is there something in our process that we need to change? And we're trying to come up with a plan to prevent this from happening again. So if it's a system factor, then okay, we need to go back in and we need to change our policies. If it was an individual error, then okay, we need to look at why that person made that error and either perform retraining. There is a potential for punitive action or corrective action. And then our failure mode effect analysis, that one is prospective. So you are likely not going to be seeing that like one-on-one unless you're in some kind of committee that's looking at policies for the hospital, or if you're in management. But these are prospective analyses, so we're actively looking for potential errors or system failures. So we're looking at, okay, well, this is what we want to do in the future. This is a policy we want to implement. What could go wrong? And if that does go wrong, what could happen from it? So really looking at potential unsafe conditions to try and prevent those from happening in the future. Thank you. And then just to throw it in there, the IRIS and SAFE reports, those are typically going to be root cause analyses. So our different types of institutional cultures, if we can go forward one. So there is punitive culture, and this is the idea that any kind of mistake or error should be punished. And it's focusing on the individual instead of any kind of precipitating factor. So if there was a system flaw, you did exactly what you were supposed to do according to the procedure that was laid out for you, but an error still happened. Punitive culture doesn't take that into account. It just sees you made an error. And then I would ask if you all could think of any pros and cons for a punitive culture. I don't know if anyone wants to jump in the chat and drop something in. If not, okay. Dylan, a click, please. So, yes, exactly. That is one of the biggest issues. Yep. So if you all can't see the chat, we have a con. It's dissuading people from admitting that they've made a mistake, or it makes people not want to take any kind of responsibility for their mistakes because they're afraid of being punished. And that's it's one of the biggest issues actually with the punitive culture approach. Dylan, if we could have 3 more clicks. Yep. There we go. So in punitive culture, you're suppressing error reporting because just like Eden and Matthew said, people don't want to admit that they're the one that made that mistake because they're afraid of being punished. And in turn, if we're not reporting mistakes, we're putting patients at risk. Whether that be from allowing an unsafe process to continue on, so reduce system improvement, or we're allowing someone that is unsafe to be practicing whatever field they're practicing, whether that be nursing, a physician, a pharmacist, a technician. We're letting them keep doing the same things that caused that error in the first place. And then it also leads to stress, turnover. Your staff isn't going to trust you if you punish them for every little mistake, which again just is a vicious cycle So still not going to be reporting. You're still going to have reduced safety. You're still going to keep doing the same policies or procedures that caused the error in the first place. And then if we can go to the next slide. So another type of culture that we hear about a lot, or if you don't hear the actual name of it, you'll hear the results of it. So this is our just culture. It focuses on a shared accountability. We're trying to find and correct the cause of whatever error has occurred. We want transparency. We want reporting. At Owensboro Health, we, in the pharmacy specifically, have what we call safety huddle twice a day, every single day. And we're calling out unsafe conditions or potential unsafe conditions, things that people need to look out for. If we have two patients on the same floor that have the same name, we want everyone to know about that. If I made an error the day before, then a lot of pharmacists will self-report during safety huddle. There was one earlier this week. It was, we got a consult to dose warfarin and the pharmacist forgot to put the note in. So she reported during safety huddle and they met afterward. We're trying to see, oh, well, what caused this? Okay, you were really busy that day. Do you need extra help on your floor? And then we have different types of behavior that contribute to errors. We have human error, at-risk behavior, and reckless behavior. And which one of those, the behavior that you were performing contributed to your error that you made, it helps guide the action in the just culture approach. So, Dylan, if we will go to the next slide. So, managing errors in a just culture, it's not like a punitive culture. It doesn't just say, oh, you made an error, we're going to punish you for it. It looks at, oh, okay, so you had a human error, which is like a slip, a mistake, you forgot something. So we're going to be looking at process improvement. We're going to be looking at additional training. With human error, one of the articles that I really liked that was breaking these down compared it to you accidentally ran a stop sign. You didn't mean to run the stop sign. You didn't see it and say, oh, there's a stop sign. I don't want to stop. It was an accident. Then we have at-risk behavior. So that's when you understand that there's a risk, but you don't think that risk is important. It's insignificant, or you think that you're justified in continuing to do what you're doing. So the example for that one was speeding. You know you shouldn't speed. You know that, that increases your risk of having a wreck or being injured in a wreck, but you don't think that'll happen to you. It's justified. So with that, in the just culture approach, it's usually let's coach someone to increase their awareness. Let's model healthy behaviors. Let's reward them for exhibiting those healthy behaviors. And when you increase awareness and reward the healthy behaviors, you're less likely to continue making or exhibiting that same at-risk behavior. You're aware that speeding is a good way to put someone in the hospital or yourself in the hospital. And then reckless behavior it falls under the more severe category, with the action that we take in response to this. So you know that there's a huge risk. You know the risk is unjustified. You don't care. So with our driving example, that would be you're driving drunk. you know you shouldn't be. You know you're putting yourself and everyone else at risk, and you do it anyway. So with that, the just culture approach does actually recommend a remedial or a punitive action because you knew that what you were doing was wrong. You knew it was a huge risk, and we definitely need to do something to correct this. And then, timed perfectly. Dr. Malcolm, have y'all been doing a 5 or a 10-minute break?
Typically 10.
Okay, that works for me. So it is 10:57 if y'all want to be back at 7 after.
Becca, do you want to try to, because I think you have most of the second half slides. Do you want to try to flip this over to yours during the break?
Yes, that would be great.
I can
think
try, also I can try doing it from my end and then giving you all control. I'm not sure if I can do that.
I think it might be easier. At least let's try to see if Becca can
Yeah, go ahead and do that.
share. I think you have to do presentation and then after share.
Like
See, I
share
was
that
in the
screen. That's what you're saying, Dylan, right? Like share that when you go down to share, it'll be different options. And if you are in presentation mode already, then you can share that image.
Yes, if that's possible. I also am at work operating with two monitors, so if it's potential that that makes it more difficult.
let's see. Because every time I've used presenter mode at or on Teams, it was
Like the
when I was at
presenter view.
Sullivan with the when I was with Sullivan with the updated Microsoft, and Owensboro has been slow at turning over.
Were you able to share, Becca?
So whenever I go into presenter view,
Mhm.
it doesn't show me the Teams options to actually share the screen.
So if you go into the slideshow and then hit presenter, it just basically turn it into a slideshow. Then go up to share, and then one of the either windows or screens should be the slideshow itself, not presenter view, not your desktop, not anything like that, just the slides. So like I'm doing it right now, should be anyway. And then I'm going to stop that. Actually, see if I can give you control.
I think you can give us access because when you were doing that before, I was able to like
Yeah, that
go
was different. So
forward.
what I did there was it's called PowerPoint Live, and it lets everybody do that. So anybody can go back and forth in the slides. You can actually lock it too if you want to keep them on the slide, but they can also take notes on it.
That's kind of cool.
Mm-hmm.
So unfortunately, I think I have the old version of Microsoft, and there's not actually the actual presenter view. It just says like, oh, I can play it from the beginning. I can start the
Yeah.
slideshow, but I don't have actual presenter view as one of the built-in options at the top.
Okay. Well, why don't we, Dr. Malcolm, do you mind
Yeah.
trying the share option
See
or
here.
the whatever it's called?
You are not, Becca, you are not listed in my available. This person is a meeting guest. We can't verify their identity. Fun.
Hmm.
So what's the next process for that? Dylan, I can give it to you, it looks like.
Well, I might as well just share it at that point.
I know. Take
Okay.
back.
We can try to just stick it out for the rest of the
All right.
presentation. I think there's like 20 slides left. And this is all going to be more of the stuff that you all have covered before. So it will probably be mostly review, hopefully. But I don't think that it should be a problem for us just to continue doing what we were doing, Becca.
Okay. Is everyone ready to begin again?
Yeah, go ahead.
Okay. So, like we said, or like Dr. Tulett said at the beginning, we're going to be doing a little bit of recall. So that's what a majority of these upcoming slides are. But just bear in mind, even though you've seen it before, coming from people who just took the NAPLEX, just took the MPJE, and are currently new practitioners, we're asking you to recall these things because they're important. If we can go forward. So just wanted to talk a little bit about safety organizations and error prevention, which I think most of these slides are actually, there's a mix between mine and Dylan's, but as a baseline knowledge check, I have a little poll everywhere set up. There are 2 questions, but just do the first one for now. You can either go to that web address or scan a QR code. It should be active, but let me know if it's not. So we have Iris Incident. She's a 41-year-old female. She doesn't have any known drug allergies, but she has an ear infection, and we're giving her amoxicillin. I know y'all should have had at least a little bit of your top 200 drugs so far, so you should know this one is a penicillin antibiotic. Soon after she starts her amoxicillin, she does develop some swelling and hives, and it's noted that this is an allergy. We add it to her chart, and if you go to the poll everywhere, is this an error? So let's see.
We're not going to be able to tell. You'll have to just, since you can't share your
Right.
screen, or you couldn't, we'll have to just repeat it out.
I think also
Yeah.
it's worth noting, just do the first question. Don't do the
Yeah.
second question yet.
I thought I'd already said that, but I did see someone has responded to the second one, so it's worth repeating. All right, looks like it's been 20, almost 30 responses. And we have 41 people, including me, Dylan, or Dr. Tulett, and Dr. Malcolm. So I'll give y'all another, I don't know, 10 seconds. All right, so looks like several people responded to both of the questions. One of those is a follow-up for later, but for the first question that was intended for this exercise, looks like 84% of you said no, this was not an error, and 16% said, oh, that has just changed to 87 and 13%. So 13 of you said that this is okay. So interesting. Looks like in the chat there are some issues with it, but so about 13% of you said that yes, this was an error, and 87% said no, it's not. So just recalling back to Dylan's section earlier about adverse drug events versus errors of omission or commission. This is an adverse drug event, which is not an error. And then if we move forward, this is Dylan's section.
Yeah, so starting off, I guess changing gears slightly, we'll follow back up with Dr. Doyle at the end with more on those errors. But to get a little bit into back into medication use process. At the time of like administration or dispensing of a medication, if you were in an outpatient pharmacy, but like administering a medication inpatient, let's recall the five rights, which I believe Dr. Malcolm told us that you have for sure seen before. That would be right patient, right drug, right dose, right route, and right time. So these are all the things that, you know, obviously when we're verifying an order or ordering something, we want to be clarifying more than just this. We want to know if the patient needs it, what their disease state, blah, 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 all that stuff. But when we're about to give a medication to a patient, you have to verify all of these things, knowing that any one of them could be wrong. And with that in mind, I will pass it back over to Dr. Doyle. You need to unmute still.
Pop up. I saw the pop up. All right. Dr. Malcolm has also informed us that you've seen the Reasons Swiss cheese model before, but just kind of to discuss a little bit, why are there so many steps and double checks in healthcare? How many times do you think someone, whether it be a pharmacist, a physician, a nurse, how many times do you think that someone reviews the exact same order before it actually gets to the patient? Why do they do that? So, since we're virtual, I think it'll be a little easier to just, yep. So this is exactly why. The more steps, the more double checks that you have in place, the more safeguards, the more likely you are to catch something before it actually makes it to the patient. So we talked a little bit earlier about near misses are reported, and I think you all should be at least somewhat familiar with what those are. So that's an error that happens, but it's caught before it reaches the patient. We would much rather have a near miss than an actual medication event. Not that we want near misses, but it's always better to catch it before it makes it all the way to the patient. And that's why we have so many different people looking at the exact same order so many different times, because we're trying to catch any kind of event before it actually makes it all the way through. And then that one is you, Dill.
Yeah. So I know that we're gonna start talking a little bit about like the different groups and either government or non-government agencies that kind of like have a say into medication safety. And the first one is the Institute for Safe Medication Practices. They are a nonprofit that works to prevent medication errors. They have their own med error reporting system, but they also do a lot more for medication use safety processes. We'll pass this back over.
All right. So I know you all have seen or heard of some of the many different ISMP error resources that are available. If we can have some clicks, we have the list of confused drug names. We have a list from the FDA and the ISMP for lookalike. Oh, my screen just changed. Okay. For lookalike drugs, and they recommend that you use tall man lettering or separate those medications out. They have their list of error-prone abbreviations, symbols, and dose designations. I don't know about Dylan or Dr. Tulett, but in my health systems version of Epic, if you try to type one of those error-prone abbreviations, even if it's just in a note to yourself, it'll flag it and it won't actually let you use that abbreviation. So if you try to type DC, it pops up with a little drop down that says, did you mean discontinue? Did you mean discharge? This is an error-prone abbreviation. Please select one. And all of that is based off of that ISMP list. They have a list of high alert medications in acute care settings. So a lot of these medications require dual sign-off by either 2 nurses, 2 pharmacists. So we have our chemotherapy drugs. I know at my facility, whenever a nurse is changing an insulin drip rate, 2 nurses have to sign off on that because insulin is a high alert medication. It just means you are a lot more likely to have a serious adverse effect from incorrectly administering that medication. They have their targeted safety best practices for hospitals, and it's a handy document that goes all the way through. This is what you should do in this situation. This is a way to reduce the likelihood of causing or having an error. And then they also have strategies to help prevent medication errors and hazards. So all of those are available on ISMP's website. It's a very useful tool to have in your tool belt. And if we move forward one, this is one of the tools that I think is very helpful to help differentiate between what's a system function and what is a human function and what are the uses of each. So if we can have a click, they have their high leverage system reliant safety practices. So are we forcing a function? Do we have a barrier or a failsafe? Are we using automation and computerization? So some of those examples would be, if you're dispensing an oral medication, you can't give that into someone's vein. It's not formulated for that. You could cause a serious event. So you use a syringe, you prepare the medication, dispense the dose to the floor in a syringe that you physically cannot attach a needle to that. You can't hook it up to their IV line. They have hard stops, which Dylan discussed earlier, things that the system will not let you go through without verifying or confirming that that is actually what you were intending to do, or they have some hard stops that can't be overridden. Our DKA protocol at my hospital, it's a nursing driven protocol where they're altering a patient's insulin drip based off of their protocol that's built in. They have hard stops built into that. You can't just jump from 5 units an hour to 50 units an hour. You actually can't go above 50 units an hour on the protocol at all. So that's a hard stop, something that you just can't do. The system will not let you. Robot dispensing is another one of these examples. So you're using that automation and computerization. My facility uses a robot, and because it is all computer programmed, we're not relying on an actual person to be looking at that or to be pulling that medication. Anything that comes from the robot actually does not have to have a pharmacist lay eyes on it before it goes out, because you're just not likely to have those errors with robots. And then you have your smart IV pumps, which Dylan touched on earlier as well. So if it communicates with your health system, or you can pre-program a library into your pump. So it has your drug and it has how it should be administered, or it has a standard rate that it's administered, or you can't go above a certain rate on certain medications. And your EHR and computerized order entry. So an electronic health system and electronic prescribing. Those are ways that the ISMP has shown to be very effective at reducing errors. And then with your medium leverage, so you're looking at something and the computer's looking at something. So those order sets that Dr. Tulett was showing you earlier. So you have a pre-programmed list of options that you can choose from. That's a medium way to reduce an error because you're combining those computerized, those system functions with the actual human function. Your dual sign-off, so 2 pharmacists or 2 nurses, and your verification alerts, because that is computerized, it's popping up for you to look at. However, someone can just click through and not actually review those, which kind of falls into our alert fatigue that I know you all have heard of in the past. So medium leverage, we're combining computer, we're combining people. And low leverage, so that is you're exclusively relying on the person. So all the training modules that different health systems assign, it's low leverage because yes, you are required to go through that module, but that doesn't mean you're going to remember it. That doesn't mean people are going to pay attention to the module. And you have access to electronic resources, that's low leverage. So great, the information is there at your fingertips, but are you actually looking at it? So it's relying on the person. And we're back
All
to
right.
Dylan.
So we're just going to go through a couple more organizations. The first, right, a second being the Joint Commission. Again, this is an independent organization. It's nonprofit, and they are responsible for accrediting and certifying different or all of the U.S. healthcare organizations. So that includes pharmacies, hospitals, ambulatory care centers, behavioral health, home health, long-term care facilities, and labs. And I like I I want to stress like the importance of the accreditation process to you, not just because like it's important to do things correctly. Obviously, like the CEO is going to care that we're, doing things appropriately. But it also does impact the healthcare system's like reimbursement and like ability to use Medicare and Medicaid if they're like not accredited fully. So this does have genuine impact. It's not just like some little organization that says like, good job, you're doing well. Next, we're looking at like government organizations. So the U.S. Food and Drug Administration, obviously FDA, they have 2 programs that I want to point out. The first being MedWatch and then VAERS. We'll get into both. So MedWatch is a place where you can report like adverse drug events, and there's 2 locations to do, or 2 forms that you can fill out. There's the patient form, and then there is the health professional form. Obviously, if any of us are doing this, we're going to be clicking on the health professional form, and you can find all of this if you just type in MedWatch online. And then it'll pull you in here. You just have to, similar to how Dr. Doyle went through the different error reporting systems that we use. You just fill out the information and submit it, and they kind of just like collect and tabulate all of the different med reporting data. Just pausing on VAERS for a second, which I will come back to because it is actually joint shared between the CDC and the FDA. But the CDC is another federal program under the Department of Health and Human Services. Its mission statement is to protect public health through disease prevention, surveillance, and health promotion. So they develop guidelines and different recommendations to improve things such as infection control, vaccination safety, and occupational health in all of the healthcare settings. So this isn't necessarily just exclusive to the hospital system, but it certainly is something that you will run into in the hospital system. Some important features to note about the CDC are going to be theirs, which I'll get to in a minute. And then NIOSH, which is an identified list of hazardous drugs that pose risk to healthcare workers. This list basically makes up the medications that are included in USP 800, which I know that you all have talked about before, that being the hazardous substances compounding chapter of USP. And now getting to VAERS. VAERS stands for the Vaccine Adverse Event Reporting System. And this is a national vaccine safety monitoring program. As I said before, it's managed by both the CDC and the FDA. And within it is just like a collection and analysis of vaccine adverse event reports. And so, again, they're just trying to identify potential safety concerns associated with vaccines. All healthcare professionals are encouraged to report any suspected vaccine-related adverse events. So it doesn't even, for like all of you going into healthcare, it doesn't even need to be like confirmed, I gave this vaccine. 10 minutes later, the patient had a reaction. It could just be a patient that shows up to the pharmacy or is in the hospital like, yeah, I'm having this reaction. I had a vaccine 7 days ago, 10 days ago. Like, you can report all of it, and it should all like get sort of collected and formulated into aggregate data that can be analyzed. The USP, I know that you've talked about extensively, probably with Dr. English. Again, this is the organization that sets the standards for quality, purity, strength, and consistency of medications, food ingredients, and dietary supplements in the US. They have these key chapters on non-sterile compounding, which, as you all could tell me, is USP 795. 797 is sterile compounding. And then 800 is those hazardous drugs that we talked about with the NIOSH list. Again, I won't belabor anything on here because I know that you've had this before, but just take this as an endorsement from me that this stuff does come back after you graduate when you try to get your license. I promise you, you will see questions on this. And I will pass it back to Dr. Doyle.
Okay, so I'm going to go through this really quickly so that you all have time to actually look at the activity. I know you've heard of the NCC and the MERP wheel, but I thought it was useful to note their actual definition of a medication error. So it's any preventable event that can cause or lead to inappropriate medication use, patient harm, while the healthcare professional has control of that medication. So you send them home with it and they take more than the recommended dose and have a reaction. That is not a medication error if it was appropriately prescribed. So if you prescribed the wrong dose, or if the physician prescribed the wrong dose and you verified it and they had a reaction, that would be a medication error. But if they don't correctly follow instructions, that is not. And then if we jump forward a slide, just a reminder of what the wheel looks like. I can 100% tell you that there is a very good chance that you will see this wheel after you graduate. Again, just kind of speeding forward. So I just wanted to throw out some of the examples of their different classifications. So they have in the wheel, something that causes harm is classified as one thing. If it's requiring monitoring, that's classified as a different category. If it required an intervention, or if it required an intervention necessary to keep the person alive, those all fall into what we classify that error as. Dylan, if you will click. So again, just some examples. Did they become hypoglycemic? Did their mental status change? Did we have to get a lot more labs, or did we have to take their blood pressure more frequently to make sure that they're going to be okay because of what happened? Did the surgeon have to go in and have an amputation? Did they have to debride a wound because you didn't monitor cultures and they didn't get the right antibiotic? Did they have to have naloxone? Did they become anaphylactic? So all those go into the different categories. And let me see if I can drop a poll in the chat. There we go. Okay. So we talked about Iris earlier. We are coming back to her now. So she needs another course of antibiotics. She has strep throat. Her doctor offered to give her an injection instead of making her take a full course of antibiotics for that. So they offer her Bicillin LA. She accepts. She doesn't want to have to take pills multiple times a day, and she has another allergic reaction. Is it an error this time? Oh, okay. Perfect. Looks like so far everyone has gotten it correct. So yes, this one is an error. Before, she didn't have that documented allergy. There was no way to know that she was allergic, so that was just an adverse drug event. Unfortunate, but it happens. Now we know that she has that allergy, and we're giving her a medication that she's allergic to anyway. This is now an error.
All right. Let's see if I can throw in a poll as well, real quick. So which of the following organizations is responsible for accrediting pharmacies and hospitals? I'm just going to say A, B, C, or D. All right, I guess I don't know how to do this. Throw your answers into chat. So A being ISNP, B is FDA, C is the Joint Commission, and D is the CDC. Okay, looks like we got a bunch of answers. That's definitely easier than using poll for me. And that is correct. The Joint Commission is the one that accredits pharmacies and hospitals. Which chapter of the USP deals with sterile compounding? Just generic sterile compounding. Yes, you all were ready with that. I love it. The answer is, of course, B is USP 797. All righty.
And I know Dr. Tulett mentioned it earlier that, we're reviewing some of these things because they're important and you'll see them again. USP 800 has been official for a while, but it's becoming enforceable. So you will definitely be seeing a lot of it in practice, and you'll be seeing a lot of it on exams.
Yes, absolutely. And I just also wanted to give an endorsement for one of the things that I wasn't able to present on, which was the NCC MERP. The reason that is in this PowerPoint is because both of us had multiple questions on the NAPLEX about it. So make sure that you are familiar with that. Are we doing the patient thing during presentation, or are they just submitting that as homework? I don't know what would work best on Teams. Dr. Malcolm, do you have any horse in this race?
Sorry, you like sharing the activity? Is that what you're talking
Yeah,
about?
do you think that would
Yeah.
work better on Teams, or should we just let
Yeah.
them submit that? Okay.
Well, it's probably good to share it and go over it, and then go over the questions that you have written up.
Okay.
Because everyone should have access to that now. You should be able to see in this week's material on Blackboard that there is a in-class activity materials and then a submission link. So just I sent you a copy. I just emailed you a copy of what I posted, but it's the same that what you sent me. So you
Yeah.
can just pull up the case and share that. Yeah, that'll be good.
Okay. Like, I don't know if you want to
Yeah.
go through this. You did
Okay.
most of it.
Okay, so this first page here is a simulated version of what like a home screen on an EHR might look like. So we have our patient, Iris incident. You have her baseline information, you have her allergies, her principal problem, you have her entire problem list, which if you notice, it looks a little duplicative with some symptoms in addition to the actual disease state. It looks a lot worse in real life. So that's something that you have to pay close attention to and kind of weed through, which is unfortunate. You have some of her lab values, her inpatient medications. You have some recent vitals and some micro results. And then for Iris, she came into the ED or emergency department with generalized fatigue. So she's tired. She's had weakness, some intermittent fevers, nausea, vomiting, abdominal pain. She said that she started having all these symptoms about 3 or 4 days ago, and it's gotten a lot worse over the past 24 hours. They have done imaging and they decided that she has appendicitis with a possible rupture, and she was taken for an emergent appendectomy. She's admitted. She is now status post laparoscopic appendectomy with an abdominal washout. So they're just washing out all of the nastiness from that ruptured appendix. They did surgically confirm she definitely had appendicitis. It was definitely ruptured. She's post-op day 1. She is NPO or nothing by mouth, so she can't take any oral meds right now. And for our case, just to kind of look into the background of how errors can happen, our health system here is facing budget cuts, just like everywhere, due to a recent decrease in funding. Management has emphasized a lot how important patient surveys or patient satisfaction surveys are to retain employment. If you're consistently getting poor surveys, they are threatening jobs if staffing budget gets cut. So people with the best surveys are more likely to stay than those who have terrible surveys. So some of the commonly mentioned complaints here are nursing delays and comfort related requests. So PRN pain meds or cough medicine, anxiety, and patients asking for water or they want another blanket. So a lot of these comfort related requests, that's one of their top complaints that they're having. We have Jenny, a nurse who's assigned to care for Iris, along with 4 other patients. She's never had a poor patient survey, but she has been overwhelmed with requests this shift. 4 of her 5 patients can't take any oral medications, and they're requiring all of their meds to be given through their IV. So she can't give them a cup of their meds. She has to go in and physically administer each medication. And if you remember, some medications can't be given together, so she's having to go multiple times every day. All 5 of her patients are receiving IV antibiotics, and 3 of her 5 patients have an intra-abdominal infection. So all of her patients are really similar right now. After surgery, Iris complains that she's having a lot of nausea. So Dr. Gray, her physician, gives a verbal order for Zofran 4 milligrams IV push and confirms, I'll go and put that order in a little bit, but I'm telling you, I'm going to give her some Zofran. Or I'm going to order for you to give her some Zofran. So Jenny, the nurse, she goes to the automated dispensing cabinet to get the med for Iris. She realizes the order hasn't been verified yet by pharmacy, so she can't pull it from Iris's profile in that dispensing cabinet, or Omnicell, Pyxis, whatever the hospital uses. Jenny has a lot of patients waiting on various things. So, she has people wanting those blankets, the water, and she really doesn't want to make Iris wait because she doesn't want a bad survey. So she knows they always have that Zofran in the cabinet, so she manually pulls the drug. She does an override at the dispensing cabinet, and she types ZO into the search bar. Med hasn't been verified yet. She can't scan the barcode to document the administration in the MAR. She notes on a piece of paper the time that she administers the drug. She puts the empty vial in her pocket so that she can document it later after she can actually access that function in the electronic health record. When she goes to check on Iris in a little bit and actually document that administration, Iris is still complaining of nausea, but she's also complaining of a lot of itchiness. Jenny remembers that the Zofran vial that she used was a brand new vial that she hadn't seen before. She thought it was a new brand, different manufacturer. It's always been a liquid in the past when she's administered it, but what she gave Iris today was a powder that she had to reconstitute. So she pulls out the vial to start her documentation, and she realizes that instead of Zofran 4 milligrams or ondansetron, she gave Iris Zosyn, or Piptazo, which is an antibiotic. So she immediately calls Dr. Gray to report her mistake and requests that she come examine Iris. And you should have a form that you can type up your answers. You're going to be doing a root cause analysis or an error report for what happened with Iris. So you have her chart to look at. You can look at all of the different medications that she's on. You can look at her problem. You can look at her allergies and the case, and her HPI should be available for you to reference and to kind of help decide what some of the contributing factors to what happened.
All right. Are there any questions about the um, the error reporting that you're going to do, or anything about this from either the first half or the second half?
Any questions about hospital pharmacy in general? Or the NAPLEX or graduation or
I just wanted to jump in and say that the in-class activity assignment for everybody will be to submit to complete this error report as it's listed out here, and then upload that into the place on Blackboard where it says upload for credit. So if you go into Blackboard and it says institutional health system safety in-class activity submission. I've made that due tonight by end of day midnight. So I'm sorry about the confusion from last week's in-class activity, but so this will be due by tonight at the end of the day. So just complete that before the end of the day. And I also have teaching evaluations for both Becca and Dylan here in Blackboard as well. So you should be able to see those now and complete those, please, so they can get credit and feedback for their teaching and learning curriculum. We do have just a little bit of time, Dylan, and Becca, if you want to talk about what got you interested in residency and also in your site, while we've got time.
Dylan just sent me a text. He said he thinks his team's app just crashed. So
okay,
he
that's
is no longer present, but
Gotcha.
So for me personally, what got me interested in residency in my program, I was a little later than a lot of my classmates who knew early on that they wanted to do a residency. I was still pretty undecided whenever I started API rotations because I had worked in outpatient retail for, by the time I quit, it was 9 years. So very different from what I do now. But I started my first API rotation, which was actually at my current practice site. And I loved it there. I loved being able to go on rounds with the providers and make interventions right then and there for patients. And found out that the location had a residency program, and that kind of tipped the scales for me and made me want to apply because I really enjoyed how they did things and everything that they did.
Okay. Does anyone have any questions for Dr. Doyle?
Did I do any research before graduating? Before graduating, no, I did not. However, most residency programs do have a required research project. So currently, I am in the middle of my research project, which is looking at outpatient IV antibiotics for some of our more complicated infections. And I'm comparing Dalvance or dalbavancin, which you'll learn a lot about with Dr. Harding, and your more standard IV antibiotics. And then a lot of programs also have an MUE or a medication use evaluation, which I'm working on completing my results from. I have a poster to present on at mid-year, and then we're going to be looking at some facility changes, and my MUE was conducted over our DKA or diabetic ketoacidosis protocol. So not before graduating, but you'll definitely, if you go the residency route, you'll definitely have a chance for research whenever you're there.
All right. Anyone else have any questions for Dr. Doyle? All right. Very much appreciate it. I will send out an announcement a little bit later today, hopefully here in just a few minutes with the just some more reminders and stuff. But I appreciate everybody jumping on and accommodating the change in schedule here. I hate it really because I know that the residents like to come back and teach, particularly when they graduated from Sullivan. So it's a little different online, but actually reminds me of the pandemic. Unfortunately, that was a lot of what we did during that time period. I'm sure you all remember. But All right. We will see you next week in class. So thank you all very much. All right.